how long do you guys usually wait for people to, should I just start? It's probably 7:35. Okay. All right. So let's start then, because we have to start this late, I guess. So my name's Victor. I'm one of the anesthesia R3s. I haven't been here in a while, so it's always nice to be back. Thanks for inviting me to do the talk this morning. This morning I'm going to talk about the use of thromboelastometry to guide transfusion management. And I'd like to thank Dr. Muhammad Ali for supervising the talk. So obviously I don't work for any of the companies that make this technology, so there's no conflicts of interest during this talk. The objectives of this talk are to understand the basics of viscoelastic testing, and there's a few brands out there. The main ones are TEG and Rotem. Those are proprietary brand names, but they are based on the same technologies. There's slight differences, but for the most part we can kind of consider them to be the same. I'm going to go through how to interpret the Rotem results in order to guide transfusion management, and we'll talk about some of the advantages compared to previous or traditional lab tests of coagulation. And then we'll touch on some of the evidence in a few clinical areas, mainly trauma and postpartum hemorrhage. So the way the test works is that you take whole blood and you put it into a cuvette. So that's the red thing here, and then there's a pin that goes in the middle. The pin is restricted by a spring that essentially detects the rotation. So you've got this pin sitting in your blood sample, and it rotates back and forth. And as your clot forms, the restriction of rotation of that pin is detected by the light source over there. It's not really letting me use the cursor here, but you can get a sense of what's happening. So those black lines there are supposed to depict, I guess, fibrin strands and clot formation, and you can see that as that occurs, the amount of rotation on the pin is restricted, and that is what's detected by the Rotem machine, which will then compute a graph for you. And that basically depicts clot amplitude versus time. So what is Rotem actually supposed to tell you? Well, compared to the old coagulation test, it's supposed to be more of a global assessment of hemostasis, so it gives you an idea about the amount of time it takes to form a clot and also the clot strength. As the test is being done in real time, you can actually see the curve as it's plotted, so it gives you real-time data with useful information quite quickly. It does give you information about quantitative platelet function, not so much qualitative platelet function, which I'll talk about later. That's sort of one of the downsides to the test. And it gives you an idea about fibrinogen function in terms of quantitative levels and also the function of fibrinogen. And one of the neat things about Rotem is it actually gives you quantitative data about fibrinolysis, which most tests traditionally haven't really given you much data, or they were very difficult to interpret. Originally, when they came out with Rotem, it was marketed as a way to determine if, in the OR, if you had a patient who was bleeding, whether or not it was surgical bleeding versus an abnormality in coagulation, if it wasn't apparently obvious in that case. So we'll go through how to interpret the Rotem data and the curves. So it can be complicated, but generally it's very quick to pick up because there's only a few values that you really need to know in order to use it. So this is a typical Rotem curve. You can see that the x-axis is time in minutes, and so that's what you're looking at for when the clot starts to form. The y-axis is amplitude, and the amplitude is supposed to reflect the strength of the clot. So you can see in the bottom left with the clotting time, the CT value, that's supposed to represent your coagulation factor function. The definition of CT is basically from when you start to go to 2 millimeters of amplitude, the amount of time it takes to form a clot that's at 2 millimeters. And then clot formation time is sort of a continuation of that, where they define it as the time it takes to go from 2 to 20 millimeters. And then you look at the amplitude at various values. So for example, an A5 value, which you can see on the screen there, is supposed to depict amplitude at 5 minutes. But you can pick any number you want. So A10, A15, A whatever. Generally, the ROTEM takes 60 minutes to run, so that's usually the end of the test. The MCF is your peak clot strength, so it's maximum clot firmness. And then the second half of the graph is useful in terms of information regarding fibrinolysis. So as you can see, as a clot forms, it goes to a peak at the MCF and then gets broken down. So the Li30 is a lysis index. You can pick 30 minutes or basically any time parameter you want to calculate. And you can detect fibrinolysis at this point. So we'll go through some examples of what different curves and different situations look like. But the thing to remember about ROTEM is it's more of a testing modality rather than a single test. So depending on what you add as your activating reagent to the test, you can test different parts of the coagulation pathway. So the extrinsic pathway is analogous to the prothrombin time, and what you would do is, in this case, you would add tissue factor, and they've designated this test as XTEM. The INTEM, there's one for intrinsic pathway. The FibTEM tells you about fibrinogen function and quantity. If you're using this in the cardiac OR and you want to look at residual heparin effect, the HepTEM is a useful add-on as well. And one specific test that will tell you about reversibility in fibrinolysis and therapy in fibrinolysis is the APTEM. The AP stands for aprotein, which they add to reverse it. So if it corrects, then you kind of know that there's some fibrinolysis going on, but you would probably give TXA rather than aprotein these days. So this is what a normal curve looks like. It's actually more important to just look at the overall shape of the curve rather than looking at specific values. Most labs, when they report these, will have reference ranges, although they're not shown on this curve here. So the big ones to pay attention to for the most part are the XTEM and the FibTEM. So the top left and bottom left. So in the case of someone who's got fibrinogen deficiency, if you can just look at the overall shape, don't look at any of the numbers right now, but compare this to normal, you can see that the amplitude on the top left curve and the bottom left curve is quite a bit thinner. So based on what we know, the amplitude, let's say for example the MCF value which we're looking at, correlates mostly with either fibrinogen level or function or quantitative platelet function. So in this case, because we've got an abnormal XTEM and an abnormal FibTEM, we can attribute that mostly to fibrinogen deficiency. So in this clinical scenario, if a patient was bleeding with this ROTEM results, it's telling us that we should give fibrinogen and then maybe recheck it, and if it's still abnormal, maybe give some platelets. So same example, we can see that the shape on the XTEM is abnormal, so what you would do next is look at the FibTEM on the bottom left, and we can see that that's roughly a normal shape. So the test is telling us that fibrinogen is okay in this case, so if the patient was bleeding, we should consider giving platelets. And obviously if you treat the patient, you can reassess in a defined amount of time. With hyperfibrinolysis, you see that the clot starts to break down. If you can compare it to, I'll just show you the normal again just for comparison. You can see that it doesn't really start to break down within the time frame that they've shown here. But with hyperfibrinolysis, you can see that it kind of goes towards a tail at the end, and very rapidly the clot is degraded. And the neat thing about this is if you look at the bottom right hand, when they've added aprotein into this case, it completely inhibits the fibrinolysis. So in this case, you would have a patient, if they were bleeding, it would suggest that you should give something like tranexamic acid. And if you're looking at the numbers themselves in that, you can look at the ML value, which is the maximum lysis, and that's shown to be 100% in this clinical scenario. With the coagulation factor deficiency, it's probably a lot more straightforward to interpret. you can see that the clot takes quite a while to start forming. So specifically, we're looking at that CT value, basically that green line at the beginning. So normal clotting time should be less than 100 seconds, but in this case, it's 852 seconds. So this would suggest that we should give coagulation factors in this case. But it could also be a heparin effect, so there's things that you have to sort of keep in mind with any test. So this is an example of a ROTEM-guided resuscitation algorithm. Specifically, this is the one used at VGH in the setting of trauma. So there's multiple different examples and different cutoff values, but a lot of them focus primarily on the XTEM values and the FibTEM to optimize fibrinogen. So there's a ton of data that you can get from ROTEM, but really when you look at the algorithms, there's only a few numbers that you really have to look at in order to guide clinical decision making. So in scenario 1 on the top left here, you can see that exactly as the case we went through, you got an abnormal MCF on the XTEM with a low FibTEM. So in this case, we would opt for fibrinogen to optimize a patient who was bleeding. In the second case there, this one here, you can see that the FibTEM is normal, so that would suggest that platelets are the issue if the patient was bleeding. In scenario 3, the clotting time is prolonged, so that makes sense that we should give coagulation factors. And just to keep in mind, ROTEM is obviously just one more tool in the whole clinical picture. So if you happen to be resuscitating a major trauma with a balanced resuscitation and you're giving lots of PAC cells, then obviously you're going to probably give FFP as well. So just keep in mind that not all of the decisions in the clinical scenario should be driven by ROTEM, but rather used as sort of one extra tool in the armamentarium. And in scenario 4, you can see that when the lysis index exceeds sort of roughly 10 to 15%, that indicates hyperfibrinolysis. Most of the literature uses 15% as a cutoff, and that would suggest that you should give more TXA. And that's sort of the value in being able to quantify fibrinolysis, because a lot of the algorithms, like in CRASH 2, they use fixed dosing, and there's no way to really assess whether that's outside of if the patient stopped bleeding, but there's no way to really quantify the effect or need for redosing. So this gives you a tool that you can potentially use with results that come back quickly. Yep.
In trauma, I don't see it on this protocol, but oftentimes we can have a patient that potentially we're resuscitating for 30, 60, 90, 120 minutes, depending on how rapidly they're bleeding, whether it's a surgical issue or not. If there's a surgical issue, when the OR is ready, we try and get them up as quick as possible, but we're then resuscitating in the OR as well. Is there any guidelines on how often you should be potentially repeating the ROTEM test to guide your ongoing resuscitation?
So the question was, in a trauma situation where the patient's bleeding actively, are there recommendations or guidelines regarding frequency of using the ROTEM test? The short answer, as far as I know, is no. There aren't actually a whole lot of guidelines, especially in North America, about what to use for the frequency of testing. There are threshold values that are suggested by the American College of Surgeons, and specifically in the trauma setting, but they don't make specific recommendations saying you should retest after 30 minutes or 10 minutes. I think it's more, at this point, there aren't any studies to provide that data. So really, it's more of a clinical judgment call. So if you've given a ton of products and some TXA and you want to reassess whether or not that's had a significant effect or whether you're significantly behind, then you can do it as frequent as you want.
Cardiac surgery, well, based on what we just talked about, takes a good 10 minutes. The A5 is not validated yet. The 10-minute amplitude is the only one that's validated against the overall final amplitude. So by the time you draw the sample, parts, and you run the sample and you get to 10 minutes, close to it, you're looking at 15 minutes overall, maybe 20 depending on where the sample is and where you're running the test in lab or up in the OR. So if you have 90-minute resuscitation, you could theoretically, and that would sort of make sense to do it every 15, 20 minutes. given a round of products, and postpartum hemorrhage would be the other situation where it could probably change that quickly in the clinical scenario. So in hearts, we oftentimes, and I've seen big changes over 15, 20 minutes often. Normal row temp, surgeon says we have a lot of bleeding, do it again, it's abnormal.
So you're saying basically maximum frequency would be 15?
I think so, Guy. I think once the 5-minute amplitudes become more practical, and the new versions come out of the ROTEM where it's just one sample, you put it in, you don't have to pipette it, then you could get down to, I think, a 5-minute interval. Practically speaking, I don't think you're going to get a lot of products in 5 minutes necessarily. So I think the 15-minute, 20-minute mark,
Certainly.
2 or 3 an hour kind of makes sense clinically.
Certainly in the trauma end of things, I mean, I talked to the ROTEM rep and stuff, and he was saying that, yeah, they have the cartridge now that runs all 4 tests at once. And, I mean, we would need to probably, bigger discussion as though it would have to probably be housed in the lab instead of the trauma bay, and you have a remote monitor and stuff, so that way ICU and trauma could access it and stuff. So realistically, as Luke's saying, it's probably you're looking at least 20, 25 minutes between samples by the time you see the results coming out, drawing out a sample, everything.
Yeah, I will talk about which values are validated, but there's more and more data about the A5 that's coming out that looks promising. All right, so in terms of comparison to previous traditional coagulation lab tests, things like the INR and PTT and quantitative fibrinogen levels, well, the ROTEM gives you more of a global assessment of coagulation. And you kind of have to keep in mind the historical perspective for some of the coagulation tests, like the PT and the INR were really designed to monitor specific things like warfarin therapy, and were never designed to be used outside of that context. Certainly not in the way that we use it seemingly on any patient who is bleeding. And the other big advantage is that you can detect hyperfibrinolysis. So there wasn't really a good test that could quantitate this previously. The closest thing was probably a D-dimer, but that was fraught with, unreliability, impossible to interpret in a patient who was critically ill, and it took quite a bit of time to come back. So not fast enough for trauma or any exsanguinating patient. It gives you information about quantity of fibrinogen and quality. And in terms of the speed, it's much faster than the traditional coags, even in a massive transfusion protocol where the labs are expedited. You've got a dedicated porter. If you've got this at the bedside, which you can do because it's a point of care capability device, you can get results as soon as once you start running it, you can get useful results within 5 to 10 minutes. So some centers in the U.S., especially big trauma centers, they park these machines in the trauma bay. They've got them in the cardiac OR, as they do here. St. Paul's has it in the cardiac OR. You can put them in the centralized lab so that anybody can use it, sort of similar to the way Vancouver General has it set up currently. So now, what are the downsides to ROTEM? Well, it's not very useful for qualitative platelet assessment. So if you're looking for things like von Willebrand's disease or your patient's on aspirin or Plavix, this will not provide useful information, and that's one of the key pitfalls that people have to really keep in mind when they're looking at this, because it's more of a quantitative platelet function assessment that you'll get with that MCF value. The lab sample is actually heated to 37 degrees, so if you've got someone who's got purely hypothermia-induced coagulopathy, this is not going to be useful for you. The early versions of ROTEM were sort of plagued by reports of poor precision and inaccuracy based on lab quality testing data in the UK, but I think that's improved. But there were still some concerns about, if you had this machine in one center versus another center, the results weren't quite reproducible, which is important to know if you're going to use this to guide transfusion management. The only other downside is that there's frequent recalibration required, so you have to recalibrate this. They recommend kind of 2 to 3 times a day. So we'll quickly go through some of the evidence for ROTEM. I'm going to focus specifically on trauma and postpartum hemorrhage, but it's just because of time constraints. But just to note, most of the early ROTEM data actually comes from cardiac surgery, and now it's used quite extensively in liver transplant as well, both intra-op and post-op. So as you all know, in trauma, coagulopathy is one of the deadly triad. And more we're recognizing that the issues in trauma-induced coagulopathy kind of start with coagulation factor deficiency, consumption of fibrinogen, and then you get that hyperfibrinolysis effect, which sort of Crash 2 really brought to the forefront. And so ROTEM can help with all the three of those issues that allow you to get on with early management of trauma-induced coagulopathy. Some of the earliest data from using ROTEM in trauma came from the military. So this was an observational study in 2009 in Afghanistan, looking at all kinds of trauma. Most of these patients ended up being on a massive transfusion protocol, and what they found was the A10 values, the amplitude at 10 minutes, does predict the maximal clot firmness. And the reason why that's important is because essentially you've got a value you can obtain at 10 minutes that you can use to actually start transfusing or guiding clinical management, and you don't have to really wait for the MCF value because you don't know when you're going to get peak amplitude. It's variable between patients, could be 20 minutes, could be 30 minutes. And so the earlier you get the results, obviously the faster you can act on them. In this study, they found more coagulation abnormalities with ROTEM compared to the traditional coags, but they didn't really state what they used as the gold standard. I would assume that it was clinical evidence of bleeding. Some of the earlier meta-analyses were not very enthusiastic about ROTEM. So in 2015, the Cochrane Review looked at all of the data available at that point, and there was significant concerns about, the heterogeneity of the studies, and again, concerns about the accuracy and reproducibility of the results. And so they actually recommended in 2015 that ROTEM not be used outside of research. And so it seems like we've come a long way since then. They did an update in 2016, but obviously they included a lot more patients from different populations. So seemingly anybody who was bleeding was included in this review, so adults or children with bleeding. And they stated that using some type of viscoelastic testing can reduce need for blood product transfusion and improve morbidity. The problem with the data at this point was that most of it was coming from elective cardiac surgery, so it's hard to really apply this to trauma or postpartum hemorrhage or liver transplant. So this is one of the more recent systematic reviews. They demonstrated, similar to what Cochrane stated, that ROTEM consistently picks up coagulopathy that's consistent with clinical bleeding. And certain values that you can obtain off the ROTEM are predictive of mortality and blood transfusion requirements. So these are the values that, probably the 2 or 3 values that you should know are the values that correlate with fibrinolysis and the maximum clot firmness and the fibrinogen levels. Those are consistently studied to be probably the most important values. If you look at the studies in trauma, demonstrating hyperfibrinolysis is consistently associated with an increase in mortality, and it's quite a significant increase in terms of the magnitude as well. And so they concluded that ROTEM can be useful in early management of these patients. This was a study in BJA in 2011 that looked specifically at blunt trauma, and again they verified that a lot of the ROTEM parameters predict mortality, and those are the key ones that you want to know, because they're also seemingly the ones that are used to trigger transfusion of products. And the FibTem, which is that fibrinogen assessment test, does predict the need for red cell transfusion. So in this study, if you had fibrinolysis, your mortality was essentially increased to like 86% versus 11%. So it's quite a huge increase in mortality rates. Yep. So that's not known because the data just isn't there for that. But presumably, if you extrapolate from Crash 2, there's some type of benefit there. This was one of the first randomized trials looking at using ROTAM in trauma. So this was in the Annals of Surgery last year. What they did was they took all the trauma patients who came to their center who required a massive transfusion and resuscitated them either using thromboelastography or conventional lab tests, which are the INR and PTT. So this study didn't actually use ROTAM, that used TEG, which is American-made, but basically it's kind of the same thing, same type of technology. And they looked at 28-day survival. And this was a prospective randomized trial. They actually found quite a few findings, and they found that the people who were resuscitated according to the TEG results had reduced mortality, almost half, greater vent-free days, and more days out of the ICU. They did find a statistical significance in terms of the plasma and platelet amounts that were transfused, but if you look at the numbers, they probably aren't clinically relevant. It's more of a statistical effect. But rates of red cell transfusion are pretty much the same, which makes sense because ROTAM doesn't really tell you anything about your hemoglobin level or blood pressure, things that we use to guide red cell transfusion. That's true. That's true. Certainly not 16 or 8.5 days. So we'll switch gears a little bit and talk about the use of ROTAM in obstetrics. Primarily, this is used for postpartum hemorrhage, although there are some niche uses in obstetrics that are not validated yet, but might be coming down the pipeline. By and large, the evidence here is, I guess, there's a lot less evidence compared to other areas like trauma and cardiac surgery. It's important to keep in mind that the ROTAM values do change with pregnancy, so there are reference ranges for peripartum patients, and these were published in the BJA a few years ago. Obviously, the same issue with trauma is that if you've got a severe PPH and coagulopathy, things are happening very quickly. The traditional tests were way too slow to help you in any meaningful way. By and large, the ROTAM studies in postpartum hemorrhage tend to focus on fibrinogen, so they all look at the FibTem values and detecting hyperfibrinolysis, which is also a big thing in obstetrics now with the woman trial that just came out with using TXA. So this was one of the first studies in Journal of Obstetrics and Gynecology, and this was verification that the FibTem values are correlative with the quantitative fibrinogen levels. And this is where we get into the debate of which values are the most useful. So is it the A10, is it the A5? Because obviously the earlier you get the results, the better it is, essentially, if the accuracy stays the same. So they found that the A5, which is the value you get after 5 minutes from running the test, was 100% sensitive for a fibrinogen level less than 1.5. So obviously that's a huge thing because you have this at 5 minutes compared to a normal fibrinogen level, which I guess can take anywhere from half an hour to an hour. This was a study in blood in 2014, again verifying the predictive value of FibTem in postpartum hemorrhage. So they were able to correlate this with progression to severe postpartum hemorrhage, red cell transfusion requirements. It says here 8 units, but also greater than 4 units and greater than 8 units were associated with abnormal FibTem values, and stay in a critical care area. They do predict the need for invasive procedures, but when they defined all of this and you looked at the data, they actually didn't have any patients that went to interventional radiology, and they didn't have anyone who had a severe enough PPH to require a hysterectomy, even though these were all included in their definition of invasive procedure. But in the study, the worst that the patients got was an intrauterine balloon or uterine sutures. And the FibTem value that they looked at in this study was actually the A5. So that's good to know as well. So this was in anesthesia in 2015. It's not really a study, but they showed an example of how they've incorporated a ROTAM-guided resuscitation algorithm based on postpartum hemorrhage. And when they validated this, it said that the FibTem does predict red cell transfusions, as the previous few studies that I've shown you also do. And the biggest thing that they describe in their center is there were significant issues with getting fibrinogen levels in a timely fashion. And so that was probably the biggest advantage that they were able to obtain by switching to this algorithm. If anybody's interested in some brief review articles, these ones are quite good. They're by the same authors, looking at overall management of PPH, but they do have a section on ROTEM and how it's used in postpartum hemorrhage. And this is sort of one example of an algorithm that you would use in PPH based on ROTEM. So you can see the heavy emphasis on fibrinogen levels and detecting fibrinolysis, because you can see tranexamic acid is all over the place on this algorithm, and so is the FibTem. So this is a case report of a unique use for ROTEM, where they had a patient with an amniotic fluid embolism, which went on to develop a picture similar to DIC and started bleeding significantly. And the abnormalities they noted were severe fibrinogen deficiency and hyperfibrinolysis. And because they ran the values so quickly, they were able to get on top of that and administer TXA and fibrinogen, which, normally, I would have to say in my experience using ROTEM at VGH and ICU and in doing some of the liver cases, you give a lot less FFP when you use ROTEM, and you give way more fibrinogen. So that's sort of the big change. There are some novel uses for ROTEM in obstetrics. So there are case reports where they've got a patient with an undiagnosed coagulopathy, and the question is, can they safely undergo a neuraxial technique? And in many cases, a lot of people would have just opted for a GA just to play it safe. But there are some authors out there doing ROTEMs on these patients and then doing a neuraxial if it's normal. That isn't a validated use of ROTEM, so it's important to keep in mind the limitations. So if you think that they have a qualitative platelet issue like von Willebrand's disease, ROTEM will not pick that up, and so you have to be very careful when you do stuff like that. But it just shows you an example of the different ways in which it's coming down. I should add that there is an add-on to ROTEM that looks specifically at platelet function, so that might be more prevalent in the next few years, that does get around that problem. So it can detect aspirin, Plavix, and von Willebrand's disease. Basically, it's platelet aggregometry added on to ROTEM, so it provides even more information if you're specifically worried about platelet function. Yeah.
Here for 6 months to a year, we had purchased that foundation, the ROTEM platelet add-on. Fortunately, for whatever reason, it was withdrawn from North America. So we had it on site actually to on top of our ROTEM. And so we'll be going to another platform, the same one at VGH, but that, at least for the time being, checking with people in Munich, they're not going to be releasing surprise at North America.
Did you find it useful?
Well, we've used the PlateWorks in the past. Just
Okay.
A trial with VGH and other sites. So that gave you a qualitative overall plate count and functioning plate count.
Mm-hmm.
They're all the same, similar in terms of their methodology.
So I'm going to talk a bit about what the guidelines have to say about ROTEM, and there isn't all that much. So the Europeans have seemed to really embraced ROTEM. Again, I couldn't find that much in the North American guidelines outside of the American College of Surgeons, specifically in trauma. They recommend certain cutoff values, but they don't actually endorse using ROTEM as sort of the main test of coagulopathy in trauma just yet, whereas the Europeans are much more embracing. So they make a number of recommendations. They've stated that using ROTEM to guide transfusion can reduce costs. It is cost effective, and primarily that's in terms of saving the cost of FFP. If you look at the studies, that's where most of the cost savings come from. They said this for trauma, cardiac surgery, and liver transplant. Most of this data, you have to keep in mind, is from elective cardiac surgery in terms of cost-benefit analyses. And they state that if you've got a peri-op patient with coagulopathy, clinically bleeding, the test of choice should be ROTEM at this point. They've also recommended this in orthopedics and neurosurgery. It's a weaker recommendation with lower quality evidence. I have to say I'm not specifically sure why they focused on these areas, but it's a 2C recommendation. And they've endorsed the use of ROTEM for specifically the FibTem for looking at fibrinogen transfusion. And they do make a comment saying that it is useful for treating hyperfibrinolysis and detection of fibrinolysis. And so they would recommend giving things like TXA in this case. So overall, to conclude the talk, ROTEM gives you a more global overview of hemostasis compared to previous coagulation testing, INR and PTT, that type of thing. It allows you to see the clot formation in real time, and it allows you to individualize the blood product management a bit more in a patient who's bleeding. Because I have to say that, if you've got a borderline INR in the OR for a patient who might be oozing slightly and the surgeons aren't sure what's happening, you end up in those cases almost always just sort of giving some FFP to see what's happening. But, in this case, you can individualize based on what you see. The turnaround time is quite a bit faster, and this obviously depends on where you've put the machine. So you can put it at the bedside in the OR or in a centralized lab, so that it'll depend on how you've set it up, because obviously there's going to be time required to porter the sample to the lab if you've decided to centralize the machine. And it provides a good quantitative assessment of fibrinolysis. So especially in obstetrics with the woman trial, they used fixed dosing of TXA, so it's a gram and then repeat a gram in like half an hour. But there's no way to previously there wasn't a way to quantify that. So you really have no idea did that gram actually work, and you're just giving another gram afterwards. So this gives you a better way to just tailor that treatment a little bit more towards the patient. That's all I have. So thanks to Dr. Muhammad Ali for supervising the talk. And we have some time for questions. Thanks for coming. Yeah, Dr. Thornlow?
I was wondering on the FibTem for postpartum hemorrhage, you mentioned that the A5 was looking very good with respect to the A10 in terms of its sensitivity at picking up fibrinogens less than 1.5. Do you think that the specific population, though, the fact that pregnant population already has a higher fibrinogen to start in the 4 to 5 range is partially responsible for that increased sensitivity, and that the A5 won't necessarily be as good in other populations because of that?
That might be true. There's no evidence to refute that, but I think that it's a start in terms of, so this is the slide you're referring to here, but the issue with the fibrinogen levels in postpartum hemorrhage is that the guidelines they recommend various different levels as cutoffs for postpartum hemorrhage. So it used to be, the European guidelines still have 1 gram per liter, which is way too low, as we know now. Usually it's, if you're less than 2, and you're in postpartum hemorrhage, you've got a 100% chance of progressing and basically bleeding out more. So this is where it comes in, because seemingly the target for fibrinogen levels are constantly moving in postpartum hemorrhage. Right now, they probably sit around 1.5 to 2, which correlates well with what we see on the studies that are using the FibTem A5. But you're right, but that's also a good thing because pregnancy, the fibrinogen levels are pushed up, so it's easier to detect extremes of values. It may be different in trauma patients, but there are probably more studies in trauma and cardiac surgery looking at this, so the data is a bit more robust at this point.
Obviously, when we're in hearts, we have perfusionists and we can run ROTEMs. What do you do in the middle of the night with the postpartum hemorrhage here?
You rush things down to the OR, to the lab, and you take early.
You would have perfusion on site for a postpartum hemorrhage or coming on
half an
site.
hour, you're coming on site, by the time you've already done your first test and hopefully got a result.
I mean, if we're lucky and there's an ECMO, we can, but otherwise I don't know what you would do.
So
Yeah.
for cardiac right now, it's the perfusionists that are running the test.
Yeah.
Also calibrating the machine 2-3 times a day.
It's calibrated once a day. At the general, they're calibrating once a week. It's a bit of a bun fight right now with our lab. I'm meeting with everyone else this afternoon on a number of topics. This is one of them. But that's been a bit of a challenge in the morning during the busy setup time for Hearts getting that machine calibrated. But once it's calibrated in the morning, you're fine until next morning. So if you have a 3 a.m. test, all you have to do is turn the machine on. From a cold start, you should be able to run a sample within a handful of minutes. You do have to warm up the reagents from the fridge. That takes a handful of minutes. And just got to unplug the machine from the wall temporarily until we get the second machine sorted out in the lab, which we need to, and then wheel it over to theater 6 or theater.
So is this second machine going to the lab?
But it needs to go to the lab. It's being unused, and on another level, that's not acceptable. So I spoke with Joe Hager yesterday, and that'll be my discussion with Rodrigo. It's been a funding issue. There's centralized lab funding, and VGH got more funding, so they really justified the lab. VGH also transfuses 6 times as much plasma as we do at the site, so they have more challenges than we do. But it needs to go in the lab, and then it needs to be a functionality to actually look at that sample in the operating room, which is just a software update.
It's a remote monitor. And
Exactly, so we will get that, we paid for that, we will get that added as well. That involves Fraser Health IT, so there's been some challenge there in getting it through, but it all should come on to Meditech as well.
And through that, they're going to have remotes in
Remote, you
trauma
could be at home.
and in ICU.
Exactly, you can look at it from any portal that you can access Fraser Health through. Theoretically, look at it through your iPhone or iPad and see the result, the plot forming. And the ideal scenario, the Europeans, the surgeons are really involved, and so they have a plot forming on one of their monitors in the OR.
So it's actually real time.
They look up and they've got that plot. And that's
Yeah, it shows you the curve as it's forming. Yeah.
Are we gonna have that access?
Yeah, I mean, we don't have a lot of monitors that other than OR 12 and a couple ORs, but certainly you'll be able to access it in the operating room. And I've been working with Aaron Sloan on that, so it's just a matter of going through. A lot of things have been held up by Fraser Health, because if you think about it, this is the first new intra-operative point of care test we've had in a while. And think of all the issues we have with blood gas machines, which have been standard care for decades,
Mhm.
and they're periodic coming up and being quite aggressive with our perfusionists and about having them on site. It's been a major challenge, so getting the lab on board took us, I mean, we started talking about this, and similar talk to what you gave, excellent talk, 3 years ago. It's taking time. VGH, I know Jackie's going through some challenges there, but
It sounds like the plot formation on any sort of internet-connected
Exactly,
computer.
that
So
will be the goal.
if we wanted to have a dedicated screen, it would involve whatever, a few $1,000s to get the screen and have it plugged into one of the internet ports and put onto this dedicated.
you can have a dedicated screen, I suppose, but then any screen that can get into FHA.
Right, but
should be-
oftentimes what happens is, like in our ORs right now, right, the nurses are using that screen to put in, orders and stuff like that.
Do you have the
So-
anesthetic, where you're doing the charting?
But yeah, we've got our computers on
Computer
the
there.
anesthetic
Every
machine.
machine.
computer now.
I mean, yes, you'll have to flip back and forth potentially, but certainly, I mean, you've got the machine itself.
But I'm just thinking sort of down in the trauma bay and in ICU, it's not,
Oh, yeah.
to have well, in ICU, I guess they've got each of the ones, but in the trauma bay to have a dedicated monitor would probably be.
Yes, down there would be absolutely very helpful, so that can be discussed. We've got that all, the warranty covers what we paid, or will cover all those things. And with regard to the plate functionality, is one topic, because of purchased these things from Rotem, and then they said last minute, we can't use them in North America, so went back to the PlayWorks people, talked to Jackie, and that's what they wanted to use. There's 4 or 5 different plate function tests that you can use, or machines, modalities, and we will be bringing that. We actually have it on site, we just can't use it in the OR. So I'm trying to bypass all the official channels to get it up as soon as possible, because we had it for our trial that we were involved with here and at VGH, which was published and showed that in a randomized fashion that it was beneficial for patient care. And so I'm trying to push that with Fraser Health. They always want data. So, well, here we've done a local trial, allow us to use it for a evaluative way, research, until we actually get to the official channels, because it is tremendously helpful as their cardiac team goes. You get very I think, indirect evidence from the ROTEM. I'm not sure the other cardiac guys in the room, girls think.
Is there a plan to have all cardiac sites, or if all sites are going to have ROTEM, to have the same platelet function monitor?
Right now,
Because
no,
that would
Wendy.
make sense with all the teaching and stuff that
You're
goes
right.
on for consistency.
So I was talking to the folks down from D'Souza, Bader, the team in Kelowna, and they are switching over from TEG to ROTEM. ROTEM's done a really aggressive push in North America. Being a German company, they're very, I guess, the word I use, I guess, aggressive or insightful in realizing that we're making a shift away from cryo to more fibrinogen concentrate, target therapy, and Octaplex versus plasma. Those are all German products. This is a German machine that you sort of need to use for the German products. And I won't say they have Health Canada in their back pocket, but they've gotten things through Health Canada with a lot of support for trials. So there's this massive push to go towards a European model. The Americans, the meetings that I've been to, have a much more diverse and eclectic TEG, ROTEM, different types of coagulation or master transfusion protocols. But I think we'll be moving towards a European protocol, I think.
Dr. Kerr?
Are there any studies, as far as you know, looking at centers or areas which have introduced prophylactic TXA, for example, as we have here with the ambulance system for major trauma, who have then looked at the before and after ROTEM results to see if fibrinolysis is less of a clinical issue in major trauma in patients that do a prophylactic TXA?
I haven't read any studies that specifically look at that. I guess you would have to look at like the pre-crash 2 era versus now. And I haven't actually seen those studies, but presumably you would assume that the patients who got TXA in the ambulance on the way to a trauma center would have less severe fibrinolysis, which you could demonstrate on ROTEM. But I guess the biggest clinical addition here is that, it's very fixed values that we currently use for TXA dosing and algorithms. Doesn't matter what size patient you are, or what the individual physiology is. It's sort of 1 gram up front and then a gram over like 6 to 8 hours or something like that. But this allows you to determine whether this patient needs 2, 3, or 4 grams, which you can see when in the liver transplants on reperfusion, they often need up to 4 or 5 grams of TXA on reperfusion with a previously completely normal ROTEM. And so things really do change quite quickly, and you can really see that in real time with ROTEM.
We do have a very loaded question with a strong personal bias. I won't mention it right now, but what's your view of the utility of INR in any of these settings?
So I did my undergrad in lab medicine at UBC, so when you talk to the hematologists and the hematopathologist, they all think that we're basically a bunch of idiots using the INR and PGT to drive certain clinical decisions. And it was never, if you look at the history, it was never meant to do that, and it's never been validated for most of the use that we order INRs for nowadays. And I think the problem is a lot of times on the wards and stuff, you see someone with an abnormal INR and you automatically end up, like a lot of people, transfuse them FFP, and that isn't modern transfusion practice. At least with the ROTEM, you can reassure some of these people that clotting coagulation cascade is totally normal. You don't need to give FFP, and you can save the $1,000 worth of FFP and the potential morbidity of transfusing a blood product that isn't required.
So
Dr. Duggan?
along those lines then, do you think that we should be doing ROTEM on patients that we want to pull the epidural,
Yeah.
who have an INR of 1.5, 1.6?
Yeah, so I think that there isn't all that much evidence from ASRA in terms of that 1.5 cutoff for pulling epidurals. So I think we're going to move towards a more functional assay like ROTEM, whether it's ROTEM or TEG. I wouldn't do it at this point because it's not validated. The same reason why it would be hard to justify using this to determine whether or not you would do a neuraxial technique in someone with questionable hemostasis. I just think that the risk we're not quite there. And obviously, like, this comes up in every paper, but we probably need more data to inform that decision. But I think we're heading towards that.
I agree with Victor. I think it's again, it'll be a bold comment, but I'll make it personal bias. I think it's a completely useless test in the INR in all those settings. I don't ever do it. I mean, we do it, but in CSICU, you can't count the number of times I've had an IR 2.2, just sat on it because the rotem was normal, or the patient's not bleeding, or it's been 1.3, and the patient's whichever one's hemorrhaging out. So I don't think there's any utility to using INR yet. It is common practice to do that. I would just throw it out entirely.
Do you foresee us going to using this for patients in the community on warfarin, for warfarin monitoring?
I don't.
And INR just disappearing completely?
I don't think so, because at this point the INR is a cheaper test if you look at individually, and it was actually designed specifically for that reason.
Yeah.
So it is a reasonable test. It depends on what it comes down to in terms of cost. So some of the UK data shows that an entire panel of coag, so INR, PTT, and maybe a fibrinogen level, costs about the same as the reagent to run one ROTEM. If you don't account for the cost of the machines to do the test, that upfront cost, the cost of the reagents to do one test is roughly equivalent.
But they both give you, you'll get as much or more information with ROTEM than you would with a panel, wouldn't you?
Well, INR has a range, right?
Mm.
We don't have that range for ROTEM.
Yeah, so what it would end up being is for the XTEM, the extrinsic pathway, you would look at quantifying something like the clotting time, and then there would have to be a new range.
Mm-hmm.
But I don't see us going that way right now because of cost and the fact that INR is validated for that reason. Actually, it's only validated for warfarin monitoring.
And I think NOACs are going to advance so much that in a little while, maybe not our practice, but maybe your practice, warfarin will be something you discuss like curare or something like that.
Yeah.
Speaking of which, what did you find about ROTEM in the setting of the DOACs? You'll see it, but then it's not really correctable, right?
Yeah, I mean, it depends which.
Other
which
than with the newer reversal agents, which I think in a few years every single one will have a reversal agent.
So I haven't, outside of, there's probably some case reports of people doing it on patients with DOACs, but there isn't any validation yet, so it's not really an accepted use of ROTEM. But obviously, when they do more studies and they find there are reversal agents in the pipeline for most of the DOAC coming down, so ROTEM will probably be used as a monitoring or testing device in that setting, in those studies, I would imagine. But right now, I don't think there's any data to suggest that ROTEM is better at picking up residual DOAC effects versus traditional coag testing.
Victor, I'll ask some questions.
Sure.
Out there. It's a controversial topic. I think. What's your view of plasma use in those settings?
In the setting of DOACs.
Trauma. Is there utility? Because there's quite a bit of equipoise in Europe on this. Maybe not.
On using sort of octuplex.
Yeah, even a 1-to-1-to-1 ratio. I'll throw out a position. I think it's completely useless to pursue a 1-to-1. Again, there's not 100% evidence for this. It's not Canadian practice, but there are jurisdictions where they give targeted factor concentrates. And if they need volume, they give volume of some type versus giving this heterogeneous mix of whatever Doug's plasma has, mine has, you know. So what's your perspective on that?
So
it's more controversial, I think.
A lot of the studies using things like octuplex for correcting coagulopathies and using ROTEM to monitor this come from cardiac surgery, and there are studies looking at octuplex-driven or ROTEM-driven resuscitation using things like PCCs. I think that you could move towards very targeted therapy using volume and pure coagulation factors, but in a massive trauma initially when you don't have those settings and all the protocols are based on sort of initial resuscitation 1-to-1-to-1 or 2-to-1-to-1, depending on what you believe. I think there is value because when you give FFP, you do give a small amount of fibrinogen and it's a little bit more balanced. And in those cases where you're trying to get organized in a big trauma, you don't know what's happening. I think giving a balanced 1-to-1-to-1 is reasonable, but I think ROTEM allows you to move more quickly towards a lab-guided resuscitation. So obviously beforehand, you would do clinical assessment and 1-to-1-to-1 if you believe the military approach, and then you would move to coagulation testing guided parameters and resuscitation. But what ROTEM allows you to do is, within probably half an hour or an hour of getting the patient and you stabilize them, it allows you to catch up very quickly and move faster towards targeted therapy with specific products rather than continuing on a fixed ratio shock pack type resuscitation.
I agree, and I think we're, not to get a soapbox, we're moving, where cryo used to be, red cells, plasma plates, cryo. Cryo is kind of like, or it'll be fibrinogen concentrate relatively soon, I think, has moved up to, in our trial, it was number 2 behind platelets. I would say maybe it should be number 1, not necessarily open heart surgery, but theoretically, you can mix the stuff up pre-hospital, and the paramedics can give a bolus of fibrinogen concentrates relatively low risk, because they all show up, our aortic dissections, our traumas, our PPHs early on will have hypofibrogemia, and cryo is hard to get, and fibrinogen concentrate can be reconstituted very quickly.
Yeah, I have to say that based on looking at ROTEM in patients who are bleeding in the OR or they're in trauma or in the ICU, the first thing that seems to go is always fibrinogen. I mean, this isn't based on anything I've read, but seemingly when they start bleeding, the first thing that's abnormal is the FibTem, and then you end up giving way more fibrinogen than you would have otherwise done had you not done a ROTEM, because obviously you wouldn't have a fibrinogen level at that point.
So in those kind of settings, what would you do for volume if you're going to give concentrate? Because, I mean, plasma provides a lot of volume for us in a lot of settings. So what would be the recommendation for volume?
Probably red cells.
Yeah, well, red cells, and then the Europeans probably have more colloids than we have access to here. But then
we've moved away from colloids,
the
right?
colloids. Sorry?
Yeah. Hadn't we moved away from colloids?
Starches.
But
I'm saying there's other colloids.
so what other colloids do they have?
Well, albumin, again, there's evidence that's safe to use.
Okay.
So you can certainly, we've got lots of that in the hospital. We
Yeah.
use it all the time in open hearts now. But it's just a concept of maybe shifting away from using a lot of plasma potentially.
Yeah, I think initially I'd probably use red cells as the colloid of choice, just because in the undifferentiated trauma patients, you have no idea if they've got a TBI or things like that, where albumin is relatively contraindicated. Mm-hmm. Yeah, Dr. Thornwell?
As Europe who's more embraced this and has been using concentrates for a while, have they seen drops in TACO or transfusion-associated overload or trolley because of their decreased use of FFP? Have they seen any benefit?
I haven't.
Besides cost savings?
I haven't seen sort of the broad sort of data on that, but I know that at least in the UK, TACO overtook trolley as probably the #1 cause of morbidity based on data a few years ago. Whereas here, I think morbidity and mortality is still driven primarily by trolley, with TACO being #2. But it's reversed in the UK at this point.
Thank you very much, Victor.
Thank you.